All right. Welcome to all of our guests and our group of panelists today. We're very excited to have you all. Today, NK Presents panel is about improving access to behavioral health, both in a post-pandemic world and how that's affecting us, but also how we're going to provide under-resourced and minority groups into the communities. So we're going to talk a little bit about some of the challenges in expanding that access and what are the initiatives being undertaken and the policies that are in place to overcome them. And what are the design and technologies that are being implemented to help with all of this. So we're very excited to have our panelists. I'd like to let each of them introduce themselves, and we'll start with Faith.
Sure, so good to be here, and hello to my fellow panelists. I think this is going to be a great conversation. My name is Dr. Faith Dyson-Washington. I'm the Chief Executive Officer for Community Behavioral Health. We're a behavioral health managed care organization for the County of Philadelphia. We were started about 24 years ago, almost 25 next year, by the County of Philadelphia to administer the Medicaid Health Choices program for residents of Philadelphia. I'm a licensed psychologist by training. I come from the provider side, and so again, another reason why this conversation is important to me, as the behavioral health landscape has changed dramatically, and I think it's a great opportunity for us to continue to make sure access and quality is where it needs to be. Thank you.
Thank you. Patricia?
Sure, and I agree with the last comments. It's just an honor to be with such a talented panel, and I appreciate NK inviting us all to be here to talk about these important issues and challenges that are facing us. So I'm Trish Toole. I am the Chief Hospital Executive and President of Carrier Clinic, Hackensack Meridian Health. Carrier is one of the largest behavioral health facilities in the state of New Jersey, with a 297 licensed hospital, 93-bed long-term adolescent facility. We have 120 students in our East Mountain School, which starts at 7th grade all the way through 12th grade, as well as several group homes on the campus. And truly honored to be part of the Hackensack Meridian Health Carrier merge January of 2019. And I personally have been in the industry since 1993, mostly on the inpatient side, but again, facing many issues of stigma and challenges throughout my almost now 30-year career in the industry. And this is really one of the most challenging times coming out of the pandemic. We have made such progress in the behavioral health arena, but really feel like we're almost set back a little bit with some of the access challenges and policy changes that are before us right now. So great discussion, and again, appreciate being here today.
Thank you so much. Deborah?
Well, good afternoon, everyone. I'm Deborah Wentz. I'm President and CEO of the New Jersey Association of Mental Health and Addiction Agencies. We're celebrating our 70th anniversary year, and we represent 160 organizations statewide, both hospital-based, freestanding, in vivo, mobile response, every kind of large social service agencies. And in aggregate, they serve more than 500,000 children and adults a year. I really am grateful to NK Architects for the opportunity to bring greater awareness to the need to increase access as my colleagues, and I really feel fortunate to be surrounded by such stellar colleagues, have mentioned. The challenges of today have exacerbated the existing underlying issues and problems that the behavioral health field has encountered in terms of access. So today gives us an opportunity to shed light on what some of the issues are, some of the solutions, and how we can get there. So thank you very much for including me.
Thank you. And Teresa?
Thank you. My thank yous to NK Architects and certainly to my colleagues on the panel. It's a privilege to be a part of this discussion. My name is Teresa Wilson. They call me Terry. I have been involved in the behavioral health field. Sometimes when I think about it, I shake myself since the 70s in deinstitutionalization. I served as in the nonprofit and in the state part in the closure of state psychiatric hospitals, development of community-based services. Residential has always been a particular passion of mine and how it was developed and participating in that. I served as the Deputy Commissioner for the Department of Human Services for all disabilities, including our state institutions. After that, I went back into the community, serving those most in need, as we all do, in some of the poorest communities in the state of New Jersey. I thank you for allowing me to participate.
Well, again, I'd like to thank you all for joining us today. My name is Elizabeth Sullivan. I'm the healthcare practice leader, and I will be helping facilitate the panel of our colleagues here who's given up their time to share their thoughts on behavioral health access. So I know Deborah touched a little bit upon it in her intro, but what are the challenges in providing behavioral health care today? Obviously, the region is underbedded for behavioral health, and I think we're seeing that across the country, not just regionally. But are we also seeing long-term trend of more people seeking care, or is this just a temporary surge related to the pandemic? Faith, if you want to.
Sure, I'll kick us off with that. It's interesting because actually in Philadelphia County, we're not underbedded. We did a study a few years ago, and compared to other cities, we had more beds relative to residents. But there are definitely some trends among bed-based treatment providers. Some of that is around reduced capacity. There is some increase in bed refusals, and there's been some decrease in utilization. But there are multiple variables that are playing into that. So we're seeing, and we would talk to our provider network, and we have over 175 providers from, our large academic hospitals to our mom and pop shops. But some of the variables include staffing shortages and then just a decrease in available beds. And so just to give you some context around that, of course, during COVID-19, there was a need to quarantine after exposure to COVID, especially when, patients were exhibiting symptoms of COVID and awaiting those test results. And there was also a need to isolate. And so that really impacted what we saw providers' ability to consistently maintain adequate staffing from the onset of the pandemic, really throughout the spring of, I would even say this year, 2021. We've also documented kind of bed refusals through our quality improvement process and looked at our acute inpatient and our bed-based substance use disorder treatment providers. And the data has shown that really most of what we're hearing around bed capacity has been attributed to staff shortages, right? So unable to really staff one-on-one. And also those shortages have led to reduced bed capacity over the course of COVID. So I think the last thing I'll mention about that is providers also have reported an increase in acuity of members as well as increased acuity on units during COVID, right? So you have all of these COVID factors playing. It's a perfect storm at the same time, and that had impacted, bed availability. I will say, particularly for Philadelphia County too, we had a major hospital closure. I don't know, most of you have heard of Hahnemann's hospital closure. That was in August of 2019. And then we had a closure with Mercy Hospital, our crisis response center, March 2020. And And so all of those things too, those 3 facilities or 2 facilities really served as a safety net for some of our marginalized families and communities. And so we're still recovering from that as well. I'd like to say just a juxtaposition to that. While we're seeing and dealing with some of that, enrollment is at a historic high. So typically we hover in Philadelphia County around 620,000. Over COVID, 725,000 residents are eligible for Medicaid. That is half the city of Philadelphia, half the city. So it's huge for us, and yet we're seeing utilization is down by 14%. That's not horrible, but where is the surge that we think should be here? And since the behavioral health landscape has changed, I'm wondering where our members are showing up. They may not be showing up through the ways that they were showing up pre-COVID. And one of the good things, I think it makes it competitive, is that, they have more options now with telehealth, which I'm sure we'll get into later, but that's something else for us all to think about.
So before we get some insight from some of the other panelists, I'm just curious, what do you think is the largest contributor to the staff shortages at this point in time?
Yeah, I think it's a major just shift in workforce development, right? And so I think we had issues beforehand in terms of some of our frontline staff that really, behavioral health work, you think about the different levels of care, even from an entry-level mental health tech, it's challenging work. It takes a certain type of person to want to be committed to learning clinically what's needed and necessary to serve patients and clients and members. And so I think people are really just, attuned to, is this what I want to do? Is it worth it? Am I being paid enough? Can I do something else? Do I want to put myself at risk? Are there other options for me? So all of that, work satisfaction, employee engagement, maybe issues, even compensation that hadn't been addressed before, I think are at the surface now.
Yeah. I mean, we're seeing staff shortages in the medical fields across the board, especially in light of the pandemic. It's been quite a challenge. Terry, what are your thoughts on what are the challenges in the behavioral health setting today?
Well, thank you for the opportunity to respond. I think our doctor said it very well. Our workforce is certainly a challenge in terms of the individuals that we need to be able to fill the very difficult jobs that we have in providing 24/7 care from the emergency level to as individuals try to reintegrate. It's very difficult. Our salaries are not as competitive. We're competing with Amazon and Wawa and all the like, where our system, our state system has not been able to fully fund us. And it's always been a challenge. And we've always, I think, as providers across all of our states have worked hard to continue to assure that services are provided. But it's very difficult to be able to continue to reduce our cost and continue to provide quality of care and continue to assure the safety and health of the people we serve. So our challenges are system-wide.
Mm-hmm. And what are your thoughts about the licensing and compliance aspects and the challenges that you're facing?
That as well goes into the cost of doing business and assuring care. Our licensing standards are at least not connected to what it is that our systems offer. The state of New Jersey Department of Health licensing is not in sync, quite frankly, with the Division of Mental Health and Addiction Services. We need to be able to come together to review those rules and regulations, certainly not wanting to diminish any of those that certainly address our safety issues, life and safety issues. But in order to do that, we have to have a coordinated approach.
Sure. And Trish, can you comment a little bit about the demographics that have been making a challenge and in the changes and shifts that we're seeing in today's world?
No, absolutely. And first, I want to compliment the last two panelists. I agree wholeheartedly with everything they've highlighted with workforce and many of the challenges we had. I just want to amend a little bit too from our end. We're having more discussions with some of our local colleges and community colleges on cultivating, developing programs for technician level, even trying to think out of the box, not just general social service or nursing, but really how do we maybe even cultivate new programs to train and get the young students excited about some of these frontline jobs that we used to rely on. It's such a challenge. And, you know, as Terry said, you know, dealing with Amazons and competing in some of these areas, how do we get excitement? So much of our media is talking about burnout in healthcare, our healthcare workers being depressed, right? And it's not enticing for anyone to want to jump into this field. So already with the challenges, you know, how do we reverse some of these trends that we're dealing with to get the energy? So, you know, I appreciate all of their comments and just wanted to maybe add that along with it. But you're right, we are seeing some changes in our demographics, and especially here in the state of New Jersey, and I think nationally, especially in our child and adolescent population. Mr. Garrett, who is the CEO of the Hackensack system, actually in September held a pediatric summit on mental health because we're seeing such surges in that particular demographic. And some of that is absolutely post-pandemic. You know, as schools went underground and went virtual, you know, kids who were suffering either didn't find the camaraderie and the wraparound support services that they would find in the schools, as well as their challenges in home environments and trauma. So we are seeing tremendous surges in that arena. And, you know, as you know, Dr. Dyson-Washington talked about here in the state of New Jersey, I'm not so sure that we're underbedded in a normal year, but the surges coming out of this pandemic and the lack of wraparound services that have been missing during the last 18 months to 2 years is really showing its wear on individuals needing inpatient, the challenges in the state hospitalization, also with their staffing, reducing bed capacity. Those are all wraparound and contributing things that I think are affecting this surges, but especially in this child and adolescent population. So here at Carrier, we're actually looking at strategies and expanding those programs, and also how do we get better family support services out there. So, you know, clearly that's been a shift. And what was already emerging was within our LGBTQ community as well, and some of the discrimination and lack of support within that community. It is a huge initiative here at Hackensack Meridian Health and at Carrier Clinic. So we're also finding more surging in this particular arena, and maybe because a little bit more courage in finding programs or seeking services out could be part of that as well. So those are some of the shifting populations, but of course we're seeing surges everywhere. And recently, as published in the opiate overdoses and deaths contributing to overdoses, we've seen tremendous surges in that particular area as well.
Sure. I mean, I certainly think social awareness and the ability to diagnose patients at a much earlier age and for various types of you know, conditions that people, you know, are having, you know, more access to care, and then trying to find those resources, whether it's through telehealth or outpatient facilities. But I think that awareness socially, and then through other things that have pushed, I think, the envelope a little bit with the pandemic, that there's obviously been a greater rise and awareness. So. I'm curious, what are some of the initiatives you're undertaking to increase the access to care, and where and what type of services in which facilities, inpatient, outpatient, virtual? Perhaps Deborah can weigh in a little bit on this.
Sure. Well, first of all, thank you. Building on what Patricia just said, the population and demographics are changing in New Jersey. We're very excited about our new advocacy campaign, Diverse Spaces, Many Lives. New Jerseyans rely, I don't know if you can see this, on mental health care. And so being the most diverse state in the nation, mental illnesses and substance use disorders are highly prevalent in every age, gender, ethnic, racial, religious, and cultural group. And to achieve social justice and equity in healthcare, every individual must have access to all types of necessary services, including healthcare, housing, supported education and employment, transportation. And so that this means all access must be everywhere. So we're looking at some very interesting new models in home, like living room model settings. We, my colleagues touched on remotely via all forms of telehealth. And as we're evolving towards the future, treatment settings will continue to become more diverse and actually enter churches, synagogues, mosques, pharmacies, urgent care settings, which they have already. In fact, I know the Carrier has a behavioral health urgent care setting, which is very unique. And our campaign features success stories of individuals from the various ethnic and racial backgrounds, as well as different age groups in the lesbian, gay, bisexual, transgender, queer, or questioning community. And we see that their achievements in managing or recovering from mental illnesses and substance use disorders, which contribute to many other accomplishments, such as building relationships, earning college degrees, establishing businesses, are powerful illustrations of the importance and effectiveness of behavioral health care services. And our solution here is we need to increase funding for services to match the cost of care and provide for a stable workforce, which everyone's been talking about. Other several initiatives that are underway across the state, and integrated care are in the realm of integrated care. And it's not just mental health and substance use, it also includes primary care. Probably a prime model of integrated care is the Certified Community Behavioral Health Clinics. And that offers a wide spectrum of services and integrated care model, particularly for the most vulnerable individuals with complex needs. They provide crisis mental health services, including 24-hour, 7-day-a-week mobile crisis teams, emergency crisis intervention, crisis stabilization, but they also provide primary care screening and monitoring, targeted case management, psychiatric rehab services, and they're dramatically increasing access to medication-assisted treatment, which is the gold standard in substance use. And they're also offering treatment for alcohol abuse, tobacco use, and obesity. And they don't turn anyone away. There are no geographical boundaries. As I said, they're 24/7. And it's really a great model of the future that we want to expand further, because it treats the whole person at any time and wherever they are. And another integrated care model that we have in New Jersey is behavioral health homes, which is a service delivery model that's focused on the integration of primary care, mental health services, and social services and supports for children and adults diagnosed with mental illness. And we have multidisciplinary teams that deliver person-centered services to support individuals in coordinating care and services to reach their health and wellness goals. But behavioral health homes aren't physical sites, so design considerations need to consist of modifying spaces to provide care coordination, as well as intramural and extramural service deliveries. And two other, we have a lot of integration where models are in New Jersey. So there's the accountable care organizations, which started as the Medicaid ACO demonstration partnership, which fosters regional collaboration and shared accountability to quality and access to care. So these efforts, which began in 2011, have now evolved into 4 regional partnerships, which are the regional health teams that we have that integrate, coordinate, and align all those disconnected programs. In New Jersey, they're in Trenton, Camden, Newark, and Patterson. And very much we're excited about that. It was supposed to have been the integrated care license. People have been referring to the Department of Health and, address, licensing issues. Terry had spoken about it. Well, there's an integrated care license, which was due to be proposed and then promulgated, as rules, but due to the pandemic, it got put on the back burner because the Department of Health was addressing the health crisis. Currently, those regulations, which would be a single license rather than separate licenses for addictions, mental health, and primary care, they're sitting in the governor's office, so we hope that soon they'll be, proposed and then adopted and promulgated. But they're going to have a lot of implications for physical plant modifications for our community mental health and addiction providers in order for them to meet infection control and other requirements. And they will need funding to make that happen. And in order to link services, all providers with patients in common, are going to need to share information through electronic health records. And we're busy working with the state in getting some of our substance use providers who do not have EHRs yet aligned for that. And I'll just mention quickly, because I don't want to take too much time here, but with the, in the workforce issues, we're obviously, as is everyone, spending a lot of energy on educating members on how to, retain staff and recruit staff. And so there's many different variables in training and creating different pathways, implementing mentorship programs. And all of these have implications for space requirements and design, because we do know that with telehealth, even if it's not as prevalent as it was during the, darker days of the pandemic, we're evolving towards a hybrid service delivery system. And so workstations really are going to need to be reconfigured to accommodate different staff being on site at different times. Social distancing has to be taken into account for meetings and trainings, and that'll have implications on the design of conference rooms, auditoriums, and all designs, regardless of what they look like, are going to have to foster healthy practices such as the social distancing. And we even need to rethink how people convene in kitchen areas in offices and other treatment settings for food storage, preparation, and serving, and also in the restrooms. So physical facilities have to be welcoming, relaxing, and reconfigured to allow for exercise and socialization, but still being safe. And I guess the last thing that I will end on, I think maybe the most important factor, which ties back into our, diverse faces campaign, is that we really have to always take into account cultural differences and practices in terms of engaging people and increasing access to services. And so all service entities and office space need to really reflect different cultures, you know, with having both objects, pictures, artwork that make people feel comfortable and at home. And it's also really important that there are people who are available to address people in their own language. People are most comfortable around what's familiar, so we need to make that familiar. So you know, and even delivering services, I know through our New Jersey Mental Health Institute, our 501c3 arm, we had done 15 years of projects following the Southeast Asian tsunami. And the last project, and we train people trilingually, but there are remote areas, and there are in the United States and even in New Jersey, really, where we really don't have a lot of either technology or even, you know, staffing, and then part of the workforce shortage. I know it was always hard to get people away from certain, you know, if they were removed from certain centers. So in that case, service delivery and access had to be more innovative. And so we created, by working in rural areas, a portable toolkit. So like individuals could really get served in vivo anywhere.
Okay, well, thank you so much, Deborah. That was great. A lot of information there. And I'm curious, Faith, you know, can you talk a little bit about the integrated care and providing access, and, you know, how that's affecting payments and the different populations served?
Sure. And I'll just start by saying one of the first things we did as a payer was to quickly move to set up an alternative payment arrangement for our behavioral health providers within Philadelphia County. So as you can imagine, COVID hits, people aren't coming out of their house, you know, their homes for safety reasons, and yet we didn't want our behavioral health system to collapse. And so we came up with a formula, looked at 2019, what was our provider network doing in terms of utilization, and basically started flooding the system with money so people could stay employed, so they could figure out telehealth, figure out access, and try to maintain quality in whatever way they could. The state backed us on that, and I'm so thankful for it, because it really could have been a collapse of the behavioral health system in the midst of COVID-19. The other thing that I wanted to touch on, and I think Deborah spoke on this, was telehealth. This is major. As a payer, we weren't covering telehealth before. And so again, this is a regulatory driven practice. The state, you know, really took this by the helms and said, no, we're going to allow for telehealth, not only video, but phone only. I mean, they were really giving a lot of leeway in terms of platforms. They basically said, if you have a phone, if you have FaceTime, you know, some of that's being rolled back now, but any way you can, please connect with membership, please connect with your patients. This is a public health crisis, and we need to do, you know, whatever we can. And so I'm glad to say that with the support of the state, we're still paying for telehealth. And I think I agree with Deborah, it's here to stay. It's a hybrid model. And that's where design comes in. How can we continue to make this accessible? People are expecting it now. Telehealth has broken down so many barriers. You think about it, the snowstorm, you couldn't make it to the doctor's appointment, or, you know, your car wasn't functioning. Now it just requires a private space, right? And some technology. And so that's a win for everybody. We're encouraging our provider network to think through best practices, guidelines and standards, and some of our providers are already doing that. It's not a best fit for all diagnoses and situations, as we can imagine, right? But figuring out when it does work, how it works well, using evidence-based practices are important. Lastly, I'll end on, we do have a couple of integrated care projects, which we're excited about. We have a program with St. Chris for our kids project, and we're really enhancing screening around social determinants of health, right? And so that's just a buzzword for what are some of the other issues that families are dealing with: education and poverty and housing. How can we support that? any legal partnerships that we can support. We're putting integrated care navigators in these settings and care managers to help support those families and get the appropriate referrals in place. We're also working closely with Keystone First on integrated care plans for pregnant women. Just got off a call earlier with Mass General. We're doing a whole network training around how do we support pregnant women, and focusing on this coming out of a pandemic too. I've learned a great fact on there. 50% of all pregnancies are unexpected, which who knew, right? And so again, a pivotal time in women's lives. And so I'll stop there because I want to give other people a chance to talk. One last thing I'll say, we are looking at our provider network in terms of diversity and equity, and happy to report that 74% of our nonprofit provider agencies are minority or women operated. And so we're excited about that, excited about extending opportunities to connect to our membership.
So I want to talk a little bit more about, the access, and we'll come back to that in a minute. But Terry, what are your thoughts on telehealth at this point in time?
I can only underscore what Deborah and Dr. Faith said, is that it is essential that we assure those services are available to individuals. One of the things our clients, our individuals don't want to look like, they want access, but they don't want you and everyone else to know that they're getting care. You don't make a major announcement. You may see your doctor's name at the office, but some buildings have major signs on them, and as providers, we're proud of them, but maybe as consumers, there still is the stigma attached to that. So we don't want to live, when we're designing our homes, to provide the support and in many cases supervision that individuals may need in behavioral health. We don't want it to look like it stands out in the community. This is nothing new, but the truth of the matter is many of our individuals come in today and say, no, I don't want to live in a group home because that's what it looks like. I want to live in my own home. I want it designed where I can both function to the best of my ability, whether that's mental and or physical. And that, I believe, really encourages individuals to access the services that we have, and for our consumers to recognize that we as providers and designers of facilities don't look like there's the group home in the neighborhood, that apartment complex has consumers in it. It's just that maybe our physical space inside may look different and may not, but that they have individuals have an opportunity to participate in that design.
Absolutely. I mean, it's certainly telehealth is going to be here today, as has been mentioned. It'll be some sort of a hybrid, and it's great that the regulations have changed and allowed for some reimbursements on that now. And I think it's also helpful for people in the access and the ability to, just for the convenience, not having to take off a half a day of work to travel to and from, an appointment. So for some, it's convenient. So I want to talk a little bit more about the access, and we're talking a little bit about integrated care models and primary care, and being able to make those referrals in that way. But can we talk a little bit about the issues around intake and the number of patients admitted to the behavioral health via the ED or the emergency department to improve access? Perhaps Trish can talk a little bit about what's happening where you are.
No, absolutely. And as we've talked, we've seen surges in our emergency rooms, and it's forcing us right now to take inventory of the designs of our EDs to make sure that there is a location within the emergency department for specialized behavioral health care, to give dignity. Many of the things that my other panelists have talked about, some of our EDs within the Hackensack system already have behavioral health units or areas, others do not. So it's a great opportunity for us to take a view of that. Actually, we have an initiative right now under Mr. Don Parker, who heads up our care transformation here at Hackensack Community Health for Behavioral Health, to do that whole intake and review, but also trying to relieve the emergency departments. Under Mr. Parker, we actually started the first behavioral health urgent care in New Jersey, and we did that in partnership out of the Jersey Shore University Medical Center in an existing urgent care setting for medical, so that integrated philosophy. Right next door to that was actually a vacant storefront that we have now taken over, and that now is the Behavioral Health Urgent Care Center attached to the Medical Urgent Care Center. And this way, individuals that need care immediately, who may have gone to the emergency room because they couldn't get access to their doctor, or they couldn't, get in to see, or a family in crisis, not maybe needing a crisis center or mobile screening, can actually walk in and get the care that they need. And so we actually started this right as the pandemic hit, and it still got off and going quite well. And this year, by July, we had surpassed all of 2020 with access. And what we found too were schools using it, local communities, police referring patients, as well as the community at large. So the design of that location was interesting. The individuals that ran the medical side of it kind of approached it in a concerning way on how do we set up more barriers, and how do we have emergency call systems, all important, but it surely doesn't have that welcoming environment that we just talked about that you would see in the medical side of an urgent care center. So it was very important for us to work and design this in a way that was inviting, but yet gave privacy and ensured security. So, so it's been a wonderful initiative and a great work in progress as we talk. And I might just comment too on the telehealth. We've seen surges in that. We've embraced it. The community of patients embrace telehealth, which I think we're all very pleased about. One of the initiatives that the late Dr. Joe Miller was championing here at Hackensack was that of a digital hub. So all of the things we just talked about, telehealth, phone, use of an app, all of those things are in the vision of this virtual hub that we're talking about, and how can we access different forms of media so that we can reach our clients. And as Terry said, whether it's in the home or in an environment, or even for adolescents, and how do we do it with privacy? How do we assure the quality? Right? So these are all very exciting things, but it also makes us take pause saying, well, how do we know the quality of that service being delivered? How do we know the professionalism of the provider that's rendering that service? And I think the idea of the digital hub was bringing everyone together so that you can also monitor it, right? To make sure that quality, at least at Hackensack, that we want to put forward is there as well. So that's another exciting opportunity that we're looking at, in addition to urgent care and walk-in and ways to relieve the emergency rooms to get an individual to care as soon as possible.
And I think that also applies, at least in New York. I know that there are some issues around, behavioral health patients coming into the ED on the adolescent and pediatric side, in often finding them bed and transfer locations that they're holding them for a much longer period of time, and trying to make those environments flexible but also safe. So I think that that's really important that people are addressing that within the facilities of the main hospitals and the ED intake aspect.
I think that's a great comment, because of the pediatric issues that we're dealing with, and some of the pediatric psychiatrists don't want to rush to put a 7-year-old in the hospital, right? They want to crisis manage them more in an observation setting, but how do you make it safe, right? So you don't want to put them on a floor with a 17-year-old or a 16-year-old. How can you monitor to avoid the hospitalization and integrate it back? So I think you bring up a great point as we're looking at our areas and our crisis and our screening, especially in the younger populations. How do you do it in a way, because you may want to monitor them before you just rush to put them in a hospital bed. So that's such a great point, and very much what we're talking about here as well.
Mm-hmm. So I'm curious about, we're talking about sort of traditional and non-traditional types of arrangements in providing care. How do we make this more accessible and welcoming? Perhaps Terry can weigh in on some of the aspects of this.
Well, thank you. How can we make it more welcoming? I think I mentioned earlier, and certainly my colleagues have, our consumers, our clients, our individuals need to be also part of the process. What's more important than when you're designing your own home is to have a say in what it is that we're doing, and that our facilities, if we have to have a long-term care facility, I do love what Trish was saying about the urgent care. I mean, that is such a significant step in separating out and making welcoming environments for individuals with behavioral health crises and who their families are most concerned that we know they're part of the emergency department, but we also know that we've designed a setting that welcomes that individual in so they're more open to treatment. And as you begin to talk about treatment and provide that crisis and you move through the continuum of care, all levels should begin to look less like that most intensive setting that we've had, and that our facilities are both therapeutic and also encouraging of individuals.
So please dial 163. Melissa Roboto, please dial 116.
To be able
Right,
for
thank
individuals.
you.
That's okay. For individuals to be able to access care. So if you think about home, at the end of the day, our facilities should be designed to be that way and not to look like a hospital. When we're thinking about intensive care, it needs to be the least restrictive we can be in that intensive care setting, and at the same time assuring the health and safety of everyone.
Absolutely. I'd like to welcome any other additional comments that the panelists might like to share so that we can open this up to any attendees who might have some questions.
I think I'll just add to what Terry was saying, just in terms of leveraging technology. I think there, again, it's just a wonderful opportunity to look across demographics, age differences, diagnoses, and figure out how we can engage. And a lot of times with technology, it makes it easier to even track quality outcomes because you can get on these platforms, you can stay in touch with our patients and our members. Certain demographics prefer to put information in and have that constant contact. You can avert certain crises as well. I know here in Philadelphia, we're investing a lot into our mobile crisis teams for our children and our adults. To keep them out of the hospital. How can we support you, like Terry was saying and Tricia was saying, in place? Get you that support that you need in place so that you don't need that higher level of care, right? And so we're only using that, when absolutely medically necessary. And so, again, I think it's a great opportunity. I know across the nation, many folk are partnering CVS and these kiosks. And if we think about the opportunities that present similar to physical health, how can we check on folks' behavioral health? And how can we address the overlap? Because it's never as clean. People go into the hospital and they're dealing with both. It's that mind-body connection that exists. And so while you may have that physical health clearance for a certain issue, how are you managing? And we want to be there to support and help people to recover.
Yeah, I think it's really important that the technology has advanced, not just through the medical records, but through the telehealth. I would imagine in the healthcare settings that it's also helpful for the providers to have much more of connectivity and collaboration, whether they're in one facility or the other, to be able to completely manage, and provide a whole care team, sort of at your fingertips, and have that accessibility. So it's great how much that's advanced, and these big box retailers that are providing sort of minute clinics. I imagine that sort of the access for behavioral health is going to continue to expand out into the communities even further in some way. So Okay, any other comments or thoughts before we open it up to the audience?
I think for me, it's just making sure we have the regulatory and policy backing of some of these initiatives that we're allowed to expand and innovate on right now. Some are COVID-related waivers, at least here in New Jersey, that are allowing us to expand, especially in telehealth and some of these media related initiatives that we're doing, or allowing us to get into the house a little easier. So really, we're going to need to really have our regulators take a look at this and support us in this to have ongoing change. And I know Deborah is very passionate about that and helps here in New Jersey with many of these initiatives, both on the state and federal level. But I just felt it would be important to mention that as well.
And along with that, we need the fiscal resources to do retrofitting, both for remote and permanent work. So this includes even down to the details of like having different workstations to plug in laptops, areas for printing, copying, and faxing in different workstations, places to serve individuals in person and also through telehealth and in virtual meetings and events. And something that I think as we move to this more hybrid workforce and service delivery system, I think another consideration really should be to help employees design their workspaces in their homes. And so maybe, you know, some different templates so that they both can gain privacy when they need to when connecting to patients that they're serving, as well as getting privacy, you know, from other interfering kind of tasks going on in the home.
Yep, certainly, it's not just the work from home sort of aspect, but also in the workplace setting. When you're physically in an office today, you know, the workplace is also changing, but, you know, how do you allow people some privacy to be able to conduct you know, a telehealth visit, whether it's behavioral health or, you know, your regular, you know, doctor's visit. So that's something else to consider. And you know, certainly the access, I think, that employers are also taking into account in trying to provide behavioral health services and wellness settings in the workplace. But we do have a question from the audience. This question's for Patricia. Can you speak a little bit about the payment model for behavioral health urgent care and what level of value-based payment is used, if any?
Yeah, no, it was it's new for the payer community, and here within Hackensack, our population health group did deal with all the different payers on a bit of a bundled rate when you come in and the full access to care. So it depends payer to payer. Some it's individual coded depending on what they get, but with others it's really more of a bundled rate and unique. And you know, Horizon and Aetna had the courage, and some of the other payers, to work with us in population health to develop some of these new payment wraparounds, so that when an individual comes in and they're seeing, you know, a psychiatrist potentially, or if we have to telehealth in a specialized child and adolescent psychiatrist in addition to the social worker, of course we have a technician there. It became better to sort of do a small case related rate for that. So, so again, it was unique with many of the payers for that.
Okay, thank you so much. I don't think we have any other questions. I'll give folks another moment. But on behalf of NK, I really would like to thank our esteemed panelists, Dr. Washington, Deborah, Terry, and Patricia, or Trish. It's been a great conversation. I'm sure we could keep talking for many hours on these topics, and we really appreciate your insight and your time for today. This was a lovely discussion.
Thank you.
Any other last minute questions? Oh, 1 sec, I think we have one more. How are schools responding to providing behavioral health, particularly in light of the pandemic? Deborah?
Well, we have a very interesting kind of case history in New Jersey. We have for 30 years had a school-based youth services program in 90 of the schools. We really could, and we're fighting to expand it. And in the middle of the pandemic, just when with isolation and being at home and how important, so adolescent and children's mental health issues really skyrocketed in our in a last year's like fiscal year 2021 like proposed budget. The program was decimated. So we took to the advocacy route, and we had communities, children, principals, schools, parents, counselors, and legislators were behind us, insisting that this program was necessary. I mean, there were 40,000 signatures on a petition. There were videos with kids saying, how their lives changed. Anyway, not only was the program restored, it got an additional small amount, of $5 million last year, and we're still fighting. We would like to see this available in every school district in New Jersey, as diverse as our population is. We have, over 600 school districts as well. We want this available to every kid. They work with the school. They provide not just mental health and substance use services, help with homework, career development, mentoring, role modeling, addressing food insecurity, and really turning kids' lives around. So that's one way that we're doing that. We're bringing a lot of attention to this issue through our educational council in colleges, and we're actually working with a legislator in New Jersey, Siobhan DeSumpter, and Amy Kennedy in the Kennedy Forum. There'll be a roundtable in January or February to again gain traction from a regulatory and legislative standpoint, and increasing access and information, and of course making the budget call to include it and expand all services, so all children and youth have access to services.
Thank you so much. You all are fabulous women, and it was great to be on this panel discussion with you. Thank you again.
Thank you for having us.
Yeah.
Goodbye.
Thank you.